So let's make a video on biometry. So today's video is actually on biometry, and I want to tell you that why I'm making this video is to make sure that you understand the basic concept of biometry and how you can see biometry as a point of optics and how to understand these things as a when you are actually doing biometry in hospital setup. But at the same time, it's not about just doing thing, it's about understanding the basics of the biometry and how you should think when it comes to biometry, and small tips that will vary, that will going to be helpful in your career. So it's not about, I think it's impossible to cover all the biometry in one video. It's not possible at all, but I'll try to cover as much as possible and as much as useful. So I see in this presentation, I am not going to cover IL master and new formulas. Like there are a lot of formulas that are currently coming on, which is another story. But I'll cover few formulas, but basics things which is very important in biometry, and basic stuff how to understand optics whenever we're calculating the intraocular um, lens power. Okay, so what is biometry? The process of measuring power of an cornea, axial length of an eye, and using data determining ideal intraocular lens. So basically means biometry means measurement of biological tissue, whatever it is. So it's cornea, axial length, and usually in clinical setup, biometry means we understand that basically calculating the power of IL. But let it be whatever. Biometry means the measurement basically. So measurement of various dimensions of the eye and its components in their interrelations. That's actually biometry. This is very good definition if you want to have any definition, but I don't think that definition matters a lot. Sometimes it matters a lot because, like, let's take an example of definition of low vision. It matters a lot, but yes, sometimes that doesn't matter in that much. So if this calculation is not performed, if this calculation is not done, if it is inaccurate, then patient may be left with a significant refractive error after cataract surgery, isn't it? And that's very bad thing. If patient gets hyperopic error, and the god, that's very bad, isn't it? So within one diopter, yes, yeah, within 0.5 diopter, it's okay, but greater than one diopter, yeah, that's quite a bit different thing. So I think maybe later on, maybe 1 year later, I don't know how much time, but I want to make the presentation on how to, what are the smallest errors that we can eliminate from the biometry. But I don't know, I will work on that in recent days or not. I don't think so, but I have to have time, then I'll definitely make that video on the smallest error possible in biometry. That's quite fascinating thing that I always love to talk about. But let's move forward. Okay. And IOL intraocular lens implantation is a method of choice for correcting aphakia, yes, obviously, and for everything. The major classes of IOL based on the method of fixation so these are the very important thing, isn't it? Anterior chamber IOL, iris fixation IOL, and posterior chamber IOL. One thing I want you to understand, and from the previous class of optics, that if this is our eye and if this is posterior chamber, then power of IL, this is, let's take an example, this is place number one, posterior chamber, place number two, iris fixation, place number three, intraocular lens. Okay, so just understand this concept. Place number one, you means higher the plus power you need. Let's take example 21. Place number 2 less than 21. Let's take example 20. And place number 3 less than 2. That's, let's take example 19 or 18. So it's there, isn't it? Why it's there? Like example, why if you move from posterior to anterior, the actually IL power decreases? Because whenever you move from posterior to anterior, so this is the placement of intraocular lens, isn't it? Whenever you move from posterior to anterior, the distance between IOL and the retina increases. If distance between IOL and the retina increases at this, which means eventually power decreases, isn't it? Because power is inversely proportional to focal length, isn't it? That's very simple. So which is basically effective power. So effective basically plus lens when you move from screen away, so its effectivity increases. That's why effective power, the power of the lens decreases. So it's very central that you understand. Many of the student or many of even practitioners in optometrists think like that. For example, if PCMA IOL is 21, then reduce by 3, which is ACIL. So something like that, but it's not always there. If you are very good optometrist, then you will definitely try to understand the distance, try to understand other parameters too. But roughly, yes, reducing by 3 diopter is good estimation, but that's not always the case. So it's always there. You have to understand the position of the IL, so that you understand the why power reduces as you move from. For same example, if you put fourth IL position, which is scleral fixation, then obviously power increases, isn't it? 21.5. Let's take an example. 21.5 diopter, because the distance from IOL to retina decreases. As the distance decreases, power increases. So, which is also effective power, isn't it? So basically, this concept is very important concept you have to understand. Okay, so let's move forward. So indications, what are the indications of basically doing biometry? Obviously, IL calculation is the prime most important. Congenital glaucoma, when you want the child's eye is long because of the glaucoma pressure, or is it stretching? Definitely. Pseudoexophthalmos, so we want to know if really eyeball elongates or it's something from the posterior side, it's pushing. So posterior pole coloboma, then we will know want to know what is the thysis bulba, if literally the axial length decreases rapidly or not. So biometry is essentially consists of keratometric reading together with the ultrasonic measurement of axial length and perhaps with the measurement of ACD. So see, nowadays there are a lot of parameters that very important whenever we are trying to do biometry. Okay, but there is always three players that's central, is keratometry, axial length, and distance between cornea and lens, which is anterior chamber depth. Because let me clear it up. Because see, there are three components, isn't? One is cornea, one is lens, one is retina. We want light coming from infinity and focused on the retina. So basically, if there are two components, which is major component, that is cornea, which is keratometry, and the lens, okay, and the distance between this component, isn't it? That's what the formula you have read is a f1 plus f2 minus f into f2 into d. That's what formula is, a Goldstein formula. It's very important that effective lens, the distance between the two lens. So that's why, isn't it? It's very important. The distance between two lens is ACD. It's very important. So and eventually these two component together, what they want to do, to focus the light in retina, isn't it? To create eye imetropic. So basically this is the concept, isn't it? So that's why it's very, there are three components that's very important, is keratometry, distance between lens and the cornea, ACD, and axial length. Okay, that's three things is very important, because just understanding biometry as optics point of view. So I want to make sure that you understand biometry uh, from the lens of optics. It's very basically it's optics, isn't it? So there are always three components: ACD, axial length, and keratometry. Okay, fine. So requires the measurement and calculation of imetropic eye. Basically, what we want eye become imetropic whenever we put IL. So axial length in mm defines the distance between anterior cornea and the anterior surface of the retina. So basically, you understand axial length in mm, corneal power in diopter, and radius of curvature in mm. Okay, so corneal power in diopter or radius of curvature in mm. So basically we use basically diopter and SCD, three things. So estimate the postoperative anterior chamber depth mm defines the distance between anterior surface cornea and the anterior surface of pseudophakic lens. So it's a very very crucial thing. See, understand what we do is this cornea, and our lens, if it is cataractus, then it's obviously 4.5 mm wide, isn't it? It's quite a big. And but the intraocular lens, they are almost 1 mm or 1.5 mm thick. So, so whenever you remove this lens and you put a fine thin lens, the distance between SCD actually increases, isn't it? So pre-calculated SCD and post-surgery SCD is definitely increase. Yes, almost always. But if the distance increases, what happens there? So it matters, isn't it? What happens there? Let me ask you and let me. So f1 plus f2 minus df1 into f2. So f1 is positive cornea, f2 is positive lens, and D is always positive, F1 is positive, F2 is positive. Okay, fine. So what happens if D increases? The overall power decreases, isn't it? What do you mean by overall power decreases? If I is 60 diopter, then it becomes 58 diopter. What do you mean by that? It means I become hyperopic, isn't it? If the ACD increases, because if distance increases, what happens? This third term becomes larger, and we know this third term is always positive, and we have to reduce from this to positive, that third term, whatever it comes. Then when we have to reduce larger minus, what happens? The total power of eye reduced, and total power of eye reduced means becomes hyperopic, isn't it? If eye becomes power becomes 62, what do you mean by that? Eye is myopic. Let's take an example. 60 diopter is emmetropic. Then becoming 58 is hyperopic, becoming 62 is myopic, isn't it? So it's very simple to understand this concept, okay? It's very simple that you have to understand if there is change of SCD because of surgery. Yes, there is always, and that matters whenever we going to talk about the small errors. That matters. That really matters. Okay. Yes, not large error, but definitely small error. It matters. Just try to understand this concept. Okay, estimation of the IOL power based on the basic refraction of eye, and it has been done previously, but not now, definitely. So let me go through just rough idea. The first widely accepted method of the estimation of proper implant mass, just estimation, and made use of basic refraction, which is the refraction of patient would be your seer crystalline lens and average thickness. Basically, see, and used to use at a time when the iris fixed IOL with in wake, basically means very many years back. For each diopter of IOL change, only 0.8 diopter change in the basic refraction. Okay, so this is the concept. If patient is emmetropic, then we put to 18 diopter of IL. If patient is hyperopic, we add power on IL basically by adding power, and if is myopic, we reduce the power. So that's basically estimation. And don't just think about it now. We do biometry, which is very essential, isn't it? So estimation of IL power based on the sophisticated measurement. It is theoretically possible to reach the highly accurate estimation of IL. Theoretically, this theoretically means the gold standard I. The power by making the sophisticated measurement of the component of basic refraction and incorporate the data into several formulas. So basically, there is formulas that developed, and by theoretical formulas, we can estimate, not just estimate, we can go extremely accurate. Okay, so depending on the measurement of the predicted implant, so there are two things that is measured. What is that? The refractive power of a cornea, that's definitely K1, K2, and axial length of an eye, and the distance between anterior surface and the cornea, and basically means axial length. So first players are there was which is K, keratometry, and axial length. These are the two most important player in very early formulas. Okay, so the depth of AC, or more accurately, the post-operative distance between the basically what is very important, the post-operative, isn't it, between the anterior surface of the cornea and the anterior surface of the pseudophakic at the optical axis was used this formula as a constant, because I have already told you why it is important, because of Goldstone third component. So refractive power of the cornea, what do we do? We do keratometry, isn't it? Keratometry has again the specific place of IOL calculation, measured with the keratometry and ophthalmometry, whatever. Two principal meridian or average and obtain the spherical equivalent. See this point? Why we do this? Two principal meridian are averaged and obtain spherical equivalent. Why we do this? Because we want spherical equivalent. Why? Because spherical equivalent means circle of least confusion. Why circle of least confusion very important? Because it's the best possible place where visual acuity is high, isn't it? In Stumps interval. That's why we always do average of the two meridian because we want a spherical equivalent. So principle based on the fact that the anterior surface of the cornea acts as a convex mirror and the size, that's the principle of keratometry and I don't want to talk about it. Okay. So basically what do we mean? An error of 0.1 in radius of curve is result in refractive error approximately 0.5 diopter. You heard about it, isn't it? 1 change in keratometry, approximately 6 diopter change in power. That's very common question it asks in your every exam possible after you become optometrist, or it's very common. So it's very thumb rule. 1 change in axial length, approximately 3 diopter change in power, isn't it? Axial length 1 So it's a very common what do you call it, rule of thumb. I think rule of thumb is good. So so Java is aligned. Yes, let it be. So tips of accurate keratometry. This is very good slide. I love it. So basically, what are the tips to do accurate manual keratometry? First, calibrate and check the accuracy of keratometry. It's very important. Second, use a dedicated single instrument that is known to be accurate. Yes. Don't toss the cornea beforehand and ensure the good tear film. That's crucial. Whenever I was in the hospital and my student did a keratometry and sorry, first they in first year second year they mistakenly touched the probe and they wanted to do keratometry again, and I always just don't do this, because if you touch the cornea by probe, then doing the keratometry is very difficult, and it's very its reliability decreases. So that's why never ever do the biometry, sorry, not just axial length calculation from by touching the cornea before keratometry. You have to do keratometry first, then you will move to then you will do any invasive procedure. Okay, and make sure that is good tear film, otherwise keratometry is bad. Adjust the piece to bring the center of the cross in higher focus. Yes, that's very important. Make sure the patient's other eye is occluded and the cornea is center. It's very important, and many of the time my student didn't do that. Take the average 3 reading including axis. If high or low result are encountered, average is basically less than 40 and greater than 48, is advised the second person to check the measurement. And many of the time what I was doing is, if it's like huge uh, cornea is hugely flat or cornea is hugely steep, then I definitely wanted to use mm, corneal topography to check things. Okay, that's what I did in my clinical setups or hospital. So repeat if the difference in the keratometry power between the axes exceed. It's very important. 1.5 diopter. If scarred cornea, use the fellow eye for average result. It's very important. Always use another eye for the uh, just to check, or if one eye is totally scarred or scarred in visual axis, then you have to know the history, and then I fellow eye can be very useful. So it's a good rule of thumb. For each diopter change in K reading, 0.9 diopter change in lens powered in opposite direction. Basically means if K becomes 42 to 43, it means IOL becomes, suppose example 43 is 21, then for 43 is 20, approximately 20.1. So basically one diopter K increases means approximately 1 0.9 diopter IOL power decreases. That's very important. You have to understand this concept. Okay, this is very crucial concept. You have to understand. I will definitely come to it later. Wait. So axial length. What is excellent? Currently employing ultrasonography. So you use ultrasonography or IL master. There is without touch, without uh, what do you call it? Without invasion. So high degree of accuracy is estimated for eye axial length is very important, and I know you know this. I have already told you the 1 mm change in the axial length means approximately 3 diopter change. If ultrasound frequency is 20 megahertz or more is used, it may be possible to achieve the accuracy of 0.1. It's basically it's a different story. I'll definitely talk about it whenever we're going to talk about the ultrasonography. So let's move. So two types of age scan in ultrasonography: application age scan biometry and immersion. So basically, applanation and immersion. Immersion means not touching, basically touching, but there is a fluid between it, and applanation means directly touching. Okay. So tips for accurate measurement of axial length is ensure the machine is calibrated. It's very important. Set for the correct velocity setting. It's very important. Sometimes you do have a probe on your hand and your settings is basically patient is not basically cataractus, and you are putting the settings in, for example, silicon oil or whatever, and then it will be problematic. So it will be huge problematic. So echoes from the cornea, anterior lens, posterior lens, retina should be present and good amplitude. It's very important. Okay, I'll let me show you. Is there anything? Okay, first I'll show you later. Wait, don't push too hard. That's the very first mistake that early student always do. The students are doing this mistake like crazy. It's always there. Okay, don't push your probe too hard. If you push too hard, then what is going to be happen? The exit length decreases, isn't it? Your exit length, suppose your exit length should be 23, then you will push it came like 22. And what happen if it is come to 22? If exit length is shorter, obviously the IL power gets up. The average 5 to 10 most consistent results giving the lowest standard deviation, which is very good. Ideally standard deviation should be zero point 0.1, less than zero point 0.1. So yes, it's definitely in all of the machines. Errors may arise from an insufficient or grace corneal meniscus due to the ointment or methylcellulose. It's very important that you have to look at the cornea from the side, and you have to know that don't put anything like methylcellulose or anything like even ointment. They are very bad. So just think, just touch gently. It's very important. So misalignment along the optical nerve is recognized by an absence of scleral spike. So let me show you this point. Okay, if there is a misalignment, and what we want, we put probe and we want to hit eye at macula, isn't it? Because you want distance from cornea to macula, not cornea to optic nerve. Why? Because in optic nerve, you are not measuring distance to optic nerve. You are basically measuring distance from cornea to macula, isn't it? You want visual axis, isn't it? Yes. So it's very important if you hit optic nerve head, then one thing is very beautiful happens there. See, these things are absent. These things. There is only one spike here. Let me show you one. These things are absent. What is this? These are spike from sclera and spikes from orbital fact. Something like, let me show you once more. See, this is corneal spike. This is B is anterior cornea, anterior lens. C is posterior lens. This is VCD. This is retina, isn't it? D is retina. But EF, this is actually sclera and orbital fat. And basically in orbital fat, the spikes get down, 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 isn't it? If it is absent, then just remember that you hit the what? That you hit the optic disc, which is not at all very uh, good, because we don't want distance from cornea to optic nerve. We want distance from the macula, and if you hit macula, then there will definitely be spikes of sclera and spikes of orbital fat. It's very important. Okay, it's very important. Okay, fine. So if you hit the optic nerve, there is absence of scleral or absence of even orbital fat. Okay, the gain should be set on the lowest level at which good reading is obtained. It's very important. If there is no good reading, then you will increase the gain. Gain means basically strength, isn't it? Take care with axial alignment, especially with the handheld probe and moving the patient. So it basically means you have to be master with the holding the probe and don't misalign the probe. Okay, if you misalign the probe, then it will be problematic. So basically, what I wanted to tell you is that first spikes is always initial probe to cornea. Second spikes anterior lens capsule. Third spike C is a posterior lens capsule. C and D, the distance is vitreous chamber depth, and D is actually spikes from retina. E is scleral spikes, and the F means orbital fat. Orbital fat means it basically lowers down the spike's height, amplitude. So that's how you understand each and everything. See, if so, I will let me tell you one more thing which is very interesting to me when I was reading about it. If the height between B and C is there is high disparity, so let's make it a disparity. B is like this height and C is like this height. Okay, if this is, then there is a high chance that your probe is misaligned. So you must be cautious. B and C, anterior capsule and posterior capsule, must be equal in amplitude. It's very important. So there is a subtle thing that you can see in your basically in a scan. So and you understand things that you are doing right or not. Your spikes will give you feedbacks. So basically you have to understand small things. Okay, it's very very important. So uh, I think I'll do just two slides or more. So a scan application device calculates the axial length from the time taken for ultrasound wavelength to reflect back to its receiver from the initial internal limiting membrane. Yes, I'm definitely going to talk about in other videos because we'll talk about the ultrasonography. Then we'll definitely come to it. Okay. For each change in axial length, 2.5 diopter change in the lens implant power occurs in the opposite direction. Basically, just left it. We know 1 change means approximately 3 diopter change in the refractive error, and we know 1 change means approximately 2.5 diopter change in IL power. So let it be. This is rough estimate idea that you have to have whenever you are doing biometry. Okay. So SCD, what are the techniques that we measure the SCD? So SCD, we measure the SCD. First, A scan, ultrasonography, yes, definitely. Partial coherence interferometry, yes. Slit scanning video, yes. Simplon camera, yes. Interesting OCT, definitely yes. These are the techniques that we use. So I think I'll go next video from this. This is I talk like 28 minutes is too much long. So this is part one, and then I will definitely make part two, and in part two also I will discuss about the optics and basic stuffs that you have to understand whenever you are putting that value and try to calculate things, that why uh, like why k value increases, then k1 k2 increases, then what happens to IOL, what axial length increases, what happens to IOL, ACD increases, what happens to IOL, and there are a lot of things. And even we're going to talk about a little bit about uh, silicon oil. Okay, bis dann, I think, choose.